my name is Lukas Kenner. As I said, I'm working here in Vienna on different topics, one of which is prostate cancer, which is the second most common cancer worldwide. It's a disease of mainly old men, but more and more also younger men are affected. And it's in 80% of the cases, it's an indolent disease and quite well curable. However, in about 15 to 20%, it's a literally aggressive cancer. And the problem is here to do a proper clinical staging to improve the health status of this patient. And with low risk prostate cancer, we prefer active surveillance nowadays. And with the intermediate and high risk prostate cancers, we do basically androgen deprivation therapy. But even this is now changing. We also now going into radioligand therapies like with PSMA, for instance, for prostate cancer. So these are things which are now a current development to improve the situation. In my group, we are interested in interleukin-6 STAT3 signaling pathway. So since quite a while, so almost now 12, 13 years, we work with a mouse model, which is basically facilitating the research in our lab and our clinics here. So STAT3 is an interesting pathway which is activated by interleukin-6. So I don't know whether you can see my cursor here. Hopefully, so in the left upper corner you see the interleukin-6 receptor, which is basically a dual receptor with GP130 and the interleukin-6 receptor and activated by interleukin-6 binding, and downstream of this STAT3 can basically be phosphorylated by this dimerizing receptor and then goes to the nucleus and activates or represses transcription. And on the other hand, we have the PI3 kinase pathway, which is very important in prostate cancer. So many patients basically have a deletion in PTEN, which is the suppressor of the PI3 kinase or one of the suppressors of the PI3 kinase pathways, and many mutations occur even in a primary prostate cancer already. Yeah. And so what is basically known is that we find increased interleukin-6 levels in the serum of these patients, and we also can stimulate metastatic prostate cancer cells in vitro. But the blockage of interleukin-6 receptor was not really successful, so it was not followed up. And here I just show here what we basically modulate. So we use a QLOX-D system to either so delete STAT3 or interleukin-6 or the GP130. I will talk about later on that in these loss of PTEN mouse model. So this mice basically develop prostate cancer, and the question is what happens with the interleukin-6 STAT3 signaling axis in this tumor model. So to make a long story short, so this is basically the primary outcome, morphological outcome of this mouse model. So you see here the wild type mice, and after basically already 19 weeks of age, these mice, if you delete PTEN in the prostate epithelial cells, they develop a carcinoma, and if you delete STAT3 on top of that, these tumors become really huge. And the same happens if you delete interleukin-6 on top of the PTEN model system. So surprisingly, these tumors become very aggressive when you lose this pathway, and you also see that the prostate weight is really increasing a lot, and also the cumulative overall survival is basically reduced massively if you basically lose the STAT3 function on top of the PTEN loss. And these mice not only get tumors, they also metastasize quite quickly in different organs. So you have a really good model for metastasizing prostate cancer. So in the following years after we basically published this phenotype of those mice, basically we are also interested in the metabolism of this interleukin-6/3 pathway, because prostate cancer is a really interesting metabolic situation, and it has very much to do with the functioning of the mitochondria. So in prostate has a specific citrate cycle, which is basically regulated as a truncated citrate cycle, and it's blocked. So the aconitate is basically blocked by zinc. So you basically have the pyruvate, which enters the PDC, which is basically blocked or regulated by the PDKs 1 to 4. And with acetyl-CoA, you enter the citrate cycle. And in the case of a normal functioning prostate, the seminal fluid with a high zinc level blocks the aconitase, so you have high citrate levels. Yeah? And interestingly, in primary prostate cancer, the zinc levels drop, and also the citrate levels drop, and then basically a normal citrate cycle is possible. And then so glucose is consumed, and the lactate and citrate are consumed, and therefore basically the citrate cycle is the main driver of primary prostate cancer. And the situation changes basically in the metastatic situation, where the citrate cycle becomes inactive and a large amount of glucose are consumed, and the Warburg cycle is coming into effect. And we found basically, so we described this in 2020 in Molecular Systems Biology, but also in other publications, that PDK4, which is as a private dehydrogenase kinase, is very important in prostate cancer, especially under the situation of STAT3 loss. So it's basically we described it as a STAT3 target, and it regulates the entrance of the citrate cycle in prostate cancer. And we were then, since it was shown that LKB1, so this delivery kinase B1, which is very important also for different other cancers, but specifically also for gastrointestinal cancer, where it was shown that it can regulate PDK4. So we're very, very interested in this important kinase, and investigated basically in our mouse system, where we know that STAT3 is active and PDK4 is regulated by STAT3, and we interestingly found that LKB1 is active when basically STAT3 is upregulated by lots of PTEN. And when we basically on top of this knockout STAT3, so you basically lose this situation here of the PTEN activation of STAT3, then also LKB1 is gone. Yeah, and this basically indicates that, and here's the situation where we're using STAT3 knockout NEFs, which basically have no STAT3, of course, and they also have no LKB1. So this is also working in the situation when PTEN is there. So obviously it's a target of STAT3, and in the human situation. So we are doing liquid biopsy analysis of this PTEN and STAT3 in prostate cancer patients, and in aggressive prostate cancer patients, we see frequent co-deletions of PTEN and STAT3, which means also this is of diagnostic relevance. And so we wanted to investigate the situation, what happens when we reactivate STAT3 in this loss of PTEN situation. So we introduced a constitutive active STAT3 variant and intercrossed it with this PTEN loss of PTEN mouse model. And here is basically the Kaplan-Meier curve of the different strains we then generated. So here's the wild type mouse. This is the PTEN. This red, bright red line is Kaplan-Meier curve is the PTEN knockout. And if you on top of that lose STAT3, then you have a very aggressive tumor. And if you constitutively activate STAT3, you basically get the attenuated prostate, and the prostate cancer formation is basically gone. And this also is reflected by the by an increase, a decreased weight of the prostate. So the weight of the prostate is basically normal again. So you have no tumor formation, and this is also seen here in the histology of this mice. So basically, you come from a very metastatic situation when you lose STAT3 to a normal prostate or almost normal situation when you reactivate STAT3 in the loss of PTEN background. Of course, we were interested in the metabolism of these mice, and so here again you have this basically 4 genotypes. Here's the metastasizing genotype. Here's the primary prostate cancer with the loss of PTEN, and here's the reactivation of STAT3 in a loss of PTEN situation. And what you can see is that STAT3 is reactivated. Of course, here it's gone. And interestingly, also LKB1, which is basically lost if you lose STAT3, because the STAT3 target, you're reactivated if STAT3 is constitutively active. And also AMP kinase is activated, which is good because it's a target of LKB1. And since it suppresses the mTOR pathway, it was also for us good to see that in the situation when STAT3 is lost, mTOR is highly active, and if you reactivate STAT3, basically all the epithelial cells are negative. You have just some inflammatory cells which have basically mTOR active. So we were interested how LKB1 is regulated. So strangely here, the gene name for LKB1 is STK11, which is funny. So if you read STK11, I mean LKB1 protein. So this is the gene name. And what we did here basically is we knocked out STAT3 by shRNA, and could show that basically when you lose STAT3, you also lose LKB1 transcription. And this is also here on protein level, this is RNA level, and we then did chromatin IP and could show that basically if you lose STAT3, this is a transcriptional regulation by binding to the promoter of STK11 LKB1. So meaning LKB1 is a real transcriptional target of STAT3, and to get a better idea what happens in those tumors. So we are talking about now these mouse models, but also human prostate cancer tissue from our patient cohorts in our hospital in Vienna here. we did laser microdissection of this paraffin material, and here we have a machine where we basically can program to shoot out every individual cell. So in this case, prostate epithelial cells. So this looks then like this. So you have the ducts of the prostate, and here you can really individually shoot out the cells. And from these cells, you can basically show here that if you isolate the protein, you measure this with mass spec, so with tandem mass spectrometry. This was done in collaboration with Matthias Mann in Martinsried, and you see here that the STAT3 and STAT3 targets are activated if you lose P10, and if you lose STAT3 on top of that, all the targets are gone, and you reactivate it with the activation of STAT3, which is good, just an internal control for us. And so basically, we then were interested. So what's happening on metabolic levels, and as already indicated by the Western blot and immunohistochemical analysis, the mTOR pathway is highly active if you lose P10 and STAT3, and basically you attenuate this activation massively by activating STAT3 on one allele in the mice. And what we basically were a bit surprised, but also positively surprised that CREB, which is an important transcription factor for different, also metabolic phenotypes, is highly active when you lose STAT3, and you also attenuate this CREB activation when you reactivate STAT3. So intrigued by these findings, we wanted to prove basically this in a situation where we block the JAK-STAT pathway with ruxolitinib, which is a standard drug for JAK-STAT inhibition. And you can see that in LN-CAP cells, which are metastasizing prostate cancer cells in vitro, if you block just JAK-STAT pathway, basically you activate CREB and activate it for also phospho-CREB and activate mTOR pathway like the B6 and you lose STAT3 and interestingly also activate the androgen receptor at PSA. By knocking out STAT3, you can basically see a similar effect like with ruxolitinib, that you activate CREB phosphorylation and CREB protein and the androgen receptor, and also the androgen variant 7, which is very important for aggressive prostate cancer growth and diagnostics of those of castration-resistant prostate cancer. And PC3 cell line, this is one of the most aggressive tumor cell lines we have. It's a castration-resistant prostate cancer cell line, and this cell line doesn't express STAT3, which can basically be seen here. And if you reactivate STAT3, also here you lose the expression of phospho-CREB and CREB. So obviously also here this is targeted by STAT3, so CREB, and we then followed up possible therapeutic angles, and one of which was the idea of colleagues in Innsbruck. So this is a university town in Austria, which did a cohort of diabetic prostate cancer patients which were treated by metformin, which is a standard drug for diabetic patients. And we had the opportunity to collaborate with the guys in Innsbruck. And if you treat prostate cancer, so different grades of prostate cancer, so a low grade is basically this blue bar. Sorry, this is the benign situation of no prostate cancer. this blue bar is the metformin treated low Gleason grade, and the green bars are the high grade Gleason grades, and you see that STAT3 is increased depending if you treat these tumors with metformin, the STAT3 expression is increased, but the mTOR expression is basically attenuated. So meaning that obviously metformin can, to some extent, attenuate the mTOR expression and activate STAT3, which is good for the patients because obviously you can you get less tumor growth when STAT3 is there, which is a bit still counterintuitive to many people. So I always have to explain this several times. So this is an in vivo experiment with 2201 cells, which are castration, which are androgen responsive cell lines, which have STAT3, and in these cell lines, metformin treatment really works nicely. So you get a drastic reduction in tumor volume, and the PC3 lines which don't have STAT3 and also don't have AKB1, basically here the PC3 there's no effect of metformin. So we think that metformin would work in a situation where there's an androgen sensitive prostate cancer, where still some STAT3 is present. And here we measured basically the tumor weight in this mouse model. So we then thereafter looked at the mTOR expression in, so protein expression in patient data sets. And if you look up our paper, which we published this year in molecular cancer, so we can see that in prostate cancer, normally STAT3 and PTEN is active, but if in the cancer, basically you lose both of them and activate the mTOR pathway, which is for us a very interesting diagnostic possibility, which we also use in Vienna. And you can see this here in a transcriptional situation of another cohort of prostate cancer patients, where you see also on RNA level that the loss of STAT3 and PTEN is reflected by or accompanied by activation of the mTOR pathway. And we looked at this in different also our patient cohorts, where we see a similar situation when we go for nuclear or cytoplasmic in situations where we can measure this, also with the technology of Rupert Ecker, we can do that very nicely with this system from Dichotomous, where we basically can separate on slides tumor and nucleus. So the cytoplasm of the nucleus of every cell, and measure basically the protein expression in this situation. And also here we see that the loss of STAT3 is accompanied by the activation of an mTOR pathway. We also can see this for CREB. So basically in the tumor, CREB is activated, and high CREB levels are correlated with bad prognostic outcome. Low CREB levels are good prognostic, and this we see also on the level of biochemical recurrence, which is a stage where it is basically the indication when the PSA levels go up again after the operation or radiation therapy, and the sign of tumor recurrence, and low CREB levels are basically an indicator for a good prognostic situation in the situation of biochemical recurrence, and high CREB levels are indicator of a bad prognostic sign. And the same is true for the metastatic recurrence, where also high CREB levels are negative prognostic, and low CREB levels are basically a sign of good prognostic value. And well, here is a summary of what I just told you. So we have basically, on the one hand, the situation where STAT3 is active, which signals down through LKB1 and AMPK and inhibits mTOR, and then CREB cannot basically bind and activate transcription. And in a situation where PTEN and STAT3 are gone, you have an active PI3 kinase pathway which activates mTOR and also activates CREB to bind to the transcription machinery and drives tumor growth. So just as a take-home message, what does CREB do? Because CREB is not so widely known. It's basically an important downstream effect of mTOR and promotes anabolic processes. So it's important for cell survival, growth, and proliferation. It's a feedback in a feedback mechanism with mTOR, and basically regulating mTORC1, which is very important, as I said, for the anabolic processes. And mTORC2 also can impact CREB activity, mainly through degradation of the ACT pathway. But CREB can also be activated by other pathways, not only by mTOR, but also by the MAK ERK pathway, the MAP kinase pathway, and can influence the gluconeogenesis and insulin sensitivity, therefore also important for our metabolic phenotype. And I just wanted to mention here that Jotina Batra and Robert Ecker, which are very precious cooperation partner of mine, together with Dichotomous, we do together different projects, and the technology they have is really cool. So this is for pathologists, a real Eldorado, and I'm very happy that you have them in Australia, so you can also appreciate their precious scientific knowledge and technology. And with that, I thank you very much for your attention.